Good afternoon, everyone. Thank you so much for joining the conversation today. We're very excited to be here during Second Chance Month to support a really important topic, which is some new opportunities to help young adults in reentry through Medicaid funding.
Just listening to something hurry down.
So we're gonna start with a little bit of view of the legislation that created the opportunities for information and new guidance on this topic. And then we're going to move into a discussion panel with three leaders in the field who are really experts in thinking through the planning and implementation of how to better support young people in reentry. So the Council of State Governments is a national, nonpartisan, nonprofit organization. We're a membership organization dedicated to all three branches of government. Within the Justice Center, we're the criminal justice policy and research shop for the Council of State Governments, or CSG. How we work, we bring people together. We try to drive criminal justice system forward. We build on momentum for policy change and provide expert training and technical assistance. Part of that work is through the Second Chance Act health and housing effort supported by the Department of Justice, which is what brings us to this conversation today. Our goals are to break the cycle of incarceration, advance health, opportunity, and equity, and use data to improve justice and public safety.
Why?
So today I am joined by a panel of amazing people. So super excited to introduce everyone. First off, we have Mike Brower, who's the Criminal Justice Coordinator in Johnson County, Kansas. Mike began his career working in community mental health, specifically with youth. You can see why he was a great panelist for this discussion. He provided those services in Johnson County, Kansas jail for 7 years, and then later as a team leader for the reentry under a Second Chance Act grant. To continue reentry services, Mike worked for Douglas County Sheriff's Office for 7 years, where he assisted to start the Criminal Justice Coordinating Council. In 2019, Mike became the Criminal Justice Coordinator for Douglas County, Kansas. Then returned to Johnson County 2 years later in the same position. During his career, Mike managed multiple BJA grants and served on the Governor's Reentry Policy Council. Currently, Mike serves as the Governor's Behavioral Health Services Planning Council Subcommittee, chairs the Mental Health Services in Jails Work Group, which led to the establishment of the Kansas Stepping Up Initiative Technical Assistance Center. 2020, Mike was featured in NACO's Community Portrait for Data-Driven Justice, now familiar faces initiatives, and Mike is an alumni of University of Kansas. Additionally, we have Sheriff Peter Katusian of Middlesex County Sheriff's Office. As a prosecutor, legislator, professor, and law enforcement leader, Sheriff Peter J. Katusian has worked on leading issues in public safety and public health throughout his career. While a state representative, he oversaw Massachusetts healthcare priorities as chairman of the Committee on Healthcare. He also created and led the state's first commission on Oxycontin and other drug abuse, as well as the Commission to End Racial and Ethnic Health Disparities. As sheriff, Peter Katusian's use of specialty units has reimagined the correctional landscape. By targeting treatment towards unique populations such as young adults and military veterans, these programs have directly and substantially reduced recidivism for their participants. These results have been published in academic journals, featured by national news outlets, and labeled as best practices by multiple presidential administrations. In light of his commitment to the profession, Sheriff Katusian was elected by his statewide and national peers to serve as both the president of Major County Sheriffs Association of America and the Massachusetts Sheriffs Association. He also serves on the board of the U.S. Department of Commerce's First Responder Network Authority, and most recently was appointed to serve as vice chair of the executive committee for the Council of State Governments Justice Center. Finally, on our panel, we have Maddie Walkman, who's a director of Parent, Child, and Family Policy at Mass Health. Within this role in Massachusetts, Mass Health is Massachusetts' combined Medicaid and children's health insurance program, which covers roughly 40% of children and 40% of births in the state. In her role, she leads policy efforts around Mass Health, focused around improving health and well-being for children, families, and birthing people. Before Mass Health, Maddie was assistant director of Boston University Center for Innovation in Social Work and Health. Previously, Maddie worked with youth and families in a variety of clinical settings, including schools, hospitals, and residential treatment services. Maddie is an adjunct faculty at Boston University School of Social Work. She holds a master's in social work and public health from Boston University and a bachelor's of art from University of Michigan. And finally, I'm Sarah Worsberg. I'm a deputy division director for behavioral health at the Council of State Governments Justice Center. Within our behavioral health division, I oversee the federal training and technical assistance, which includes the Second Chance Act health and housing work, and our Medicaid and corrections portfolio, in addition to the Justice and Mental Health Collaboration Program and expanding first response to include healthcare workers and people trained in de-escalation to respond to people in crisis. So next up, we were going to talk a little bit about what brought us here today. What is the legislation that you should know about and be thinking about in preparation for January 1st, 2025? So building on the Support Act, which required suspension rather than termination for all youth, legislation prevents states from terminating Medicaid for eligible juveniles due to incarceration and continuity of care. Incarcerated youth have higher rates of physical and behavioral health conditions and may already be eligible or enrolled in Medicaid or CHIP, depending on their age. The Consolidated Appropriation Act of 2024 prevents termination of Medicaid due to incarceration, ensuring continuous care by January 2026. The Center for Medicaid and Medicare Services is planning to award money in planning grants to states to help implement some of these new opportunities. And CMS also plans to issue best practice guidance on how to help with the continuum of care. Something to note as we're discussing this on this panel is that the Center for Medicaid and Medicare Services, or CMS, actually has not issued guidance yet. So the implementation of the Consolidated Appropriations Acts for 2023 and 2024 that we're speaking about, hopefully there will be some more guidance soon from their vantage point. So we're really going to talk about the planning and implementation steps that these leaders are thinking about going through for this, knowing that we don't have that guidance from CMS yet. So just to dive in a little bit further, Section 5121 and 5120/2022 of the Consolidated Appropriations Act facilitate healthcare transitions for incarcerated youth, ensuring they receive the necessary screening, diagnostics, and case management service at the time of their release. So why for adult corrections is this such a big opportunity? So it basically means Medicaid eligible individuals who are under the age of 21 or an individual between under the age of 26 who's a former foster care youth would potentially be eligible to receive these services paid for Medicaid within the correctional facility and as people re-enter the community. So states can cover health services for these youth pre-release and provide targeted case management for at least 30 days. They can also they can emphasize sections. They can think about ways to make seamless transition of care during reentry from correctional facilities to the community to improve healthcare outcomes and stability for these youth, or as we're calling them today, young adults. They're often called transition age youth or emerging adults as well in terms of terminology. Next slide, please. So states are really encouraged to work with carceral and community-based providers to deliver required services, adhering to the Medicaid and CHIP participation and enrollment standards. There's going to be an enhanced federal financial participation that is available for state Medicaid IT systems cost, facilitating data information sharing among various agencies. So that's super important because thinking about how to share data across agencies can be daunting, but there could potentially be some funding opportunities. Corrections administrators need to coordinate with their state Medicaid agencies, legislative bodies, and community partners to think about the best practices and to really promote the best practices that correctional leaders know will work when addressing reentry from jails and prisons, and think about areas that they would like to support if they have additional opportunities. So part of the reason we're having this conversation is because the opportunities for young adults will start January 1st, 2025. And we want to make sure that correctional leaders are aware that in addition to the youth system, this is also applicable for a smaller population within the adult system as well, who are up to 21 years of age or potentially up to 26 for people who are formerly foster care youth. So there's definitely some important steps that jurisdictions can be taking to really look at this through their data and learn more about this population and think about how best to support them based on best practices around the country. From looking at data for the number of people who would potentially qualify in your correctional facilities to thinking about best practices and how to best share information to support additional funding. Another piece of this is ensuring suspension rather than termination is available in the correctional facilities and partnering with community-based providers who you think could assist in enhancing the continuity of care for young adults. Another reason this is exciting is that this opportunity is a small sample size of what some states are pursuing in regards to the Medicaid 1115 reentry demonstration waivers, which provide an opportunity for states to waive some of the Medicaid requirements to be able to provide pre-release services from correctional institutions for up to 90 days and then support people during their reentry processes. And an exciting part for this webinar is that we do have a leader from Mass Health, and they were the 4th state who just got approved for one of those 1115 reentry demonstration waivers. So our goal of the discussion today is really to provide information about the opportunity to use Medicaid to support young adults in adult corrections, to think through planning and implementation strategies that the leaders on this call recommend, and to learn from the state and local leaders on how they are approaching these new requirements and what opportunity that it does present. So we are going to switch now and move on to our panel discussion. If you have any questions as we have this conversation, please add them to the chat and we will save time for questions at the end. Okay, so just to begin with, I'm going to start with a question for Mike. What do you think the biggest opportunities are to support young adults during reentry?
Thank you, Sarah, and I appreciate CSG for giving me the opportunity to share some of my experiences and our hopes for the future here in Johnson County, Kansas. And, you know, I think this one, there is some real opportunity to one of the things that I've seen with people reentering from jail or prison back into the community is the connection to services is a tremendous predictor of their success once they're released. And this really gives us an opportunity with transitions age youth who may or may not have a family to return to. They may or may not have resources available or friends that they can stay with in the community. They're unlikely to be a homeowner. And so this provides an array of services that they can get connected to. And as I'll talk about later, hopefully an opportunity for them to actually engage with services prior to release that will be their connection in the community. It's so beneficial if I can meet the person I'm working with before they get released. And having this guaranteed access to Medicaid can be a real support in that. Having the assessments required to receive some of these community-based services prior to release or as immediately after release would also be a tremendous way to break down some of these barriers. You know, like many states here in Kansas, we have been doing this a bit with foster or children aging out of foster care, or I guess young adults. It's been really beneficial. What we've seen in the last 5-6 years is the access to housing for these individuals, assistance with transportation costs, education, assistance, and then even actually some leadership opportunities to more civically engage in their community, which I think is another important way of helping them feel connected. I'll be remiss if I don't point out the fact that Kansas is one of 10 states in the country that has not passed Medicaid expansion. So that does limit our ability. And I hope this allows us to continue the advocacy towards full Medicaid expansion here for our state.
Thank you so much, Mike. And Sheriff, I'm going to ask you the same question: is what do you think the biggest opportunities to support young adults during reentry?
Sarah, thank you very much for that. And Mike, I'm really sorry to hear about the situation with Kansas, man. That's tough. It's so much work for many of us that do have the expansion, and we know the benefit it can bring, but it's really hard when you have to actually go get that expansion in the first place, then to reap the benefit from this. So thank you for your work, and thank you for being here, honestly, today. Listen, I'm thrilled to be talking about these issues with three really bright minds. Sarah Würzburg, who I know from my work as the CSG Justice Center Vice Chair of the CSG Justice Center, Maddie Walkman, who's been integral to the Massachusetts leadership on this issue, and Mike Brower, who you heard is pulling the system together in Kansas. And I'm also excited about this panel today because for years I've been speaking, as you might have heard in my bio, I was the chairman of the Committee on Healthcare for many years before I became sheriff. So there's something that I see my work as a sheriff through the lens of public health and healthcare, and was involved in health reform here in Massachusetts. And I've been speaking on changes to Medicaid delivery through MIEP, the Support Act, and CAA since I very first became sheriff, well over, almost 14 years ago now. Now, it's so much, I've been talking about this for so much and so long that one of my staff people, who is also a health policy geek, actually wrote up a line that they wanted me to use. I'm just going to read it just for a little bit to break up this presentation about how it would transform correctional health care. And the line was this: I felt like Paul Revere here in Boston 250 years ago, yelling, "The Medicaid is coming, the Medicaid is coming." Horrible line, but I thought it would at least make people laugh. But honestly, it was kind of true, right? That's how they see me. I've been around screaming that the sky is falling for many years about this, which I think is why we're in okay shape here in Massachusetts. So sure enough, it's finally here. The waiver in Massachusetts was just approved last week. It was an immense victory won with so many contributors. I know Maddie will detail further, and it also radically impacts what we're doing, what we're talking about today with 18 through 21-year-olds. So opening up Medicaid access to this age group will supercharge our existing reentry efforts for this population. It's a group that I've long said it provides our greatest opportunity for lifelong and generational recidivism reduction and improvement of health, right? And improvement of families. So that's why we started a young adult offender program in 2018 here at Middlesex Sheriff's Office. It's called the PACT, People Achieving Change Together, as named by the individuals in custody. And it's a collaboration with the Vera Institute for Justice. And it was the first of its kind in a jail setting in the country. And at the time, the reasons were obvious. Brain science was telling us what insurance actuaries knew a long time ago, that, if you remember, they wouldn't rent a car to anyone under the age of 26. They knew it long before social and public health justice groups knew. These individuals are much more impulsive in their behaviors, lighter maturation, we think, and highest risk of reoffending. And the goals were obvious: to provide intensive CBT programming to address the unique needs of this age group. And something I always speak about from my background as a health legislator was, I always say that the health-related social needs, education, homelessness, mental health, job security, food security, and environmental concerns, and really trauma, are the identical health-related justice needs for justice needs, right? Criminological, criminogenic factors are the same ones for health-related social needs. So we aim to address those with this unit, especially trained staff, mentoring with older incarcerated adults as mentors, abundant access to mental health and trauma-informed care. It's a lot more trauma than we would even realize, quite honestly. Financial literacy classes, and a heavy focus on maintaining these positive developments during reentry. So starting on January 1st of 25, we'll have a whole new tool in these efforts. We'll be able to coordinate with Mass Health and CHIP program on case management, setting up appointments. We'll be able to point to a wider range of providers for those appointments. And by the way, those that have medical insurance coverage are 33% less likely to recidivate than those that don't have that same coverage. So it's an extremely exciting time in our world, and I look forward to bringing on the strong practice and partnerships we have in Massachusetts, and the leadership that the Council of State Governments and the Justice Center really provides, not just to Massachusetts, but across this country.
Thank you so much. And always so good to hear about the innovation within the transition age youth population that you're doing in Middlesex. So Maddie, I'm actually going to turn to you now. So a question for a Medicaid leader. Why do you want to focus on people involved in the justice system? Why do you think it's critical for other Medicaid leaders to focus on this population?
Yeah, thanks, Sarah, and thanks so much for having me. I never thought I'd be on a panel talking about health with the sheriff, but this is super exciting. So really happy to be here, and really happy to be coming on the heels of our approval to be talking about this critical issue. So this is a energizing topic for Medicaid right now, as everybody knows. We know Medicaid plays a crucial role in supporting young adults involved in the justice system. Focusing on people in the justice system is important. It's critical for addressing the intractable health disparities that we know exist, that Sheriff Katujian alluded to. And we think that by improving Medicaid coverage and needed healthcare services as people prepare to return to the community, we can really make a dent in the health disparities and promote greater racial justice and equity, and improve individual and public health. So the data is there. We know over 1/4 of Mass Health members who had a fatal overdose have been recently released from incarceration. So whether it's medicated assistant treatment for substance use disorders or prescription medication to treat chronic health conditions, we're working to ensure that people who are formerly incarcerated can transition successfully and get the support they need. So transition age youth, we know they're particularly vulnerable subgroup in the justice system, and have one of the highest rates of mental health issues, and also face multiple transitions during this critical life period and developmental period. So about 60 to 70% of Massachusetts youth in the custody of the Department of Youth Services, DYS, have at least one mental health condition. And so one of the most, as we think about this work for young adults, we're really thinking about how do we improve transitions and create a stronger bridge, particularly focus on mental health and substance use providers in the community. We also know that the health-related social needs, I'm so glad you brought that up, Sheriff Katujian, and in addition to the medical and the behavioral health needs are top of mind. Transition age youth who are DYS involved in our state are 8 times more likely to be homeless than youth who do not have DYS involvement. So as we think about medical services and behavioral health services, we're also thinking about the social needs, because we want to wrap our arms around all of the needs as youth reenter the community, because we know that the medical and behavioral health services are only okay if you have your basic needs met. So we're really excited to think about our role in screening, diagnostics, and connecting youth to services in this exciting time.
Thanks so much. And just building upon that, how can a state begin to plan for coordination for an effort involving multiple systems and the different types of institutions that Massachusetts is focusing on, from jails, prisons, and youth detention facilities.
That's for me, right? So we critical to this work has been coordinating, investing time and energy in building relationships. And Sheriff Katujian has been at the table since the beginning, and we've had a longstanding relationship with DYS, but it's even stronger now. So prior to working, prior to the 1115 demonstration request, we've had a longstanding relationship with justice agencies and a working group to address changes to the criminal justice system. And we've really built on those to do this work. We've also collaborated with the Sheriff's Association. We encourage states to engage Medicaid to engage the Sheriff Association in your state for partnership, and across the board, from DOC to probation and other partners in the implementation and planning of pre-release supports. So we're excited that our 1115 demonstration request builds off those partnerships, and in particular our parent-child family policy team. As I said, we've really built a deep collaboration with DYS, and are very grateful to our partners there and really jumping in the boat with us to do this work. So we have regular meetings, and I think we're really thinking about how do we create a cohesive structure to working together that's not ad hoc, that's really kind of standard cadence and has structure and intentionality around the collaboration now that we are deep in policy development and implementation. So thinking about how to operationalize those collaborations in a meaningful way has been critical to us.
Sarah, if I can just add to what Maddie's saying, and to underscore something she was saying, you know, the leadership in Massachusetts in the health space has been really incredible. And it's directly from Maddie and to her director, Mike Levine, to Secretary Kate Walsh, and really on to the Governor Healy, who has been behind this. And, I found doors open whenever I needed an ear. And I know from talking in many public spaces, I've spoken about this nationally a lot, because there's not many people that can speak from the correctional side of things or from the law enforcement side of things. So whether it's major county sheriffs of America, national sheriffs, law enforcement leaders, and public health conferences like Chicago and Nashville, and the RX Summit in Atlanta, and not every state has this level of coordination. And on the way out, I was screaming, Medicaid is coming, Medicaid is coming. But on the way back, I was screaming, corrections, get to the table. Correction, get to the table, right? And Maddie's just laughing because I know she heard me saying this, because it was a desperate effort, because I could see other places doing it. Very well-meaning policy, principles, policy makers were really well-meaning, but they wouldn't really understand the impact or how to make it work best with corrections and kind of reaching in and back out, especially with this age group, where the in-reach, the training, and then the outreach to the partners out there is crucially important. And I would always say, if we don't get it right, we're going to miss a once-in-a-generation opportunity to do something really important here. And so, I really appreciate that. And I'm hoping that in other jurisdictions that you can get corrections to the table, because if you do, you will mean well, and you will be thinking of everything. I've been a legislator. I know you think of everything, and I'm like, oh my God, I got everything factored in here. But the fact is, you don't, because you don't understand the industry and where those really beneficial opportunities can be there. So get your corrections to the table, to work with your policy makers, and I think you can have a great system, and that's what I believe we're about to have here in Massachusetts.
Yes, absolutely. Definitely a great example of state and local leaders being able to come together. Mike, as a correctional leader in a different state with a bit of a different context, as you mentioned in Kansas, how have you been able to start building partnerships with people within your state Medicaid agency?
So for us, we kind of have a unique model in that we have 3 different medical services agencies that kind of oversee the managed care aspect of Medicaid services. And then we have agencies that in local catchment areas are typically nonprofits, who then become the Medicaid provider of services, or those services are provided over them, whether that be mental health or whether that be for the IDD population. So for us, we, kind of have to take this unique approach of bringing all of these folks to the table. But I look at it as an implementation process that we do for a lot of things in corrections. And Sheriff, I'm super proud of the work that you've done there in Middlesex. We have followed that for a long time and even replicated some of your projects. But for us here in Kansas, it's worked really well when that lead convener, or I like to call champion of the project, is a local elected leader. Typically, the sheriff is the one that really has motivation to like I say, reduce this recidivism. And so when we have someone with that influence in the community, bring the providers together, whether it be a state agency, whether it be local nonprofits, and begin problem solving these things together, that's when we start to move forward, even if it's the smallest of steps to begin with. And one thing I've noticed, and because I've been around Kansas for a minute now, I've had the opportunity to talk to a lot of my peers. It seems like every community that champion comes from a different area, or that lead resource comes from a different area. And so I always say you don't have to do what Johnson County did. You don't have to do what Middlesex County did. Do where it works for you. Where do you have energy to begin these collaborations to start solving some of these problems together?
Yeah, I think that's a really great point. There is no one size fits all approach. We've definitely worked with counties where a prosecutor or a judge has been a huge advocate along the lines of these issues. So really just building on the strengths that you have and then educating other people to bring them along to the conversation as well. We actually did have a question in the chat, Mike, that was about your earlier comments. And this person is wondering, how can young adults be helped in acquiring documents and assessments during the reentry process?
Great question. And so, and actually, Sheriff, I was in Middlesex County last month talking about this in the reentry simulation that we did together. So obtaining documents is always a key need. Is in my career, people get released from jail or prison, and they have to go to probation or parole. And what is the first thing we tell them when they go probation, parole? We tell them, you have to get a job. But if you don't have a Social Security card, if you don't have a state ID, you can't get a job. And yet we never gave them resources to be able to do that. The interesting thing is who has the data readily available to verify this person's identity? Well, the sheriff, the jail, or the prison. And so years ago, not myself, our first reentry director in the state of Kansas went to the state and said, how can we share our information with you to provide proof that this person is who we're saying they are, so that they can get that ID. After a little bit of back and forth, we developed a one-page form, put the sheriff's seal on it, and have helped hundreds of people be able to get services. That actually then led to advocacy with multiple jails across the state. To the state now comes into our jails and will provide IDs to individuals who are preparing for reentry. So a unique way that a small step snowballs into more things happening. Social Security Administration is great with doing that. Our reentry program has received birth certificates all over from every state in the country, including we got one from Germany. That took a minute, but so that is a hurdle, but one that many of our leaders across the country have already overcome. And so definitely, so Tanya wants to share that form. I believe I can do that, Tanya. But then the second piece is getting those assessments done. This is where it really becomes tricky because completing assessments while someone is in jail takes a qualified professional whether it be for substance abuse, whether it be for mental health, or for access to the right type of diagnosis to get Medicaid funding. And those individuals, at least in the state of Kansas, typically work for nonprofit organizations. So that means if they come to our jail right now in Kansas and complete one of those assessments, they are not going to be reimbursed for that time that their employee has invested in doing that action. So that has become a real barrier for us. That's why I'm so excited when I see efforts like Sheriff Katujian has led for Medicaid expansion in prisons. That would allow us to provide that type of service. Now, I certainly know sheriffs around the country that has taken it on their own to use money out of their budget to pay for those services. Because I can't tell you the value of getting someone connected to services immediately from when they're released from jail. And so having these things lined up is tremendously important.
Yeah, absolutely. And if you're able to get those community-based providers to do inReach, it's really impactful to have that continuity of care piece that will make it easier to know someone when you go to an appointment when you're back in the community. So Maddie, I'm going to ask you, do you have any recommendations for corrections leaders on how they can partner with state Medicaid agencies? What's the best approach?
Yeah, great question. I think these initiatives have really illuminated and surfaced our shared goals in a way that makes it concrete. And so I think as an initial step, it's helpful for corrections leaders to frame partnership and Medicaid initiatives in terms of the why for their organization, so we can really thoughtfully align on shared priorities. It's been helpful to have correction leaders include their team members who have on the ground experience working with mass health in their roles in our conversations, since they often can highlight nuanced issues and potential solutions that sometimes policymakers and people in higher up administrative positions can miss or may not fully understand. And so we've really relied on the knowledge of folks on the ground in facilities to inform some of our policy development. We've also noticed the importance of language, and we have jargons on both sides, and so jargon on both sides. So being clear and explaining and reducing jargon, I think, is also critical.
Thanks so much. Definitely important. Everybody is talking a little bit about something a little bit differently. So just when we're trying to break this down to how do you do this, how to make it more manageable, I'm going to ask this question to all of you, but I'll start with Mike. From a strategic planning perspective, what steps would you take to ensure a successful integration of Medicaid services for young adults during reentry?
So anytime we're going to implement a new program, first thing we got to do is be able to identify our target population. And so I think that is something that's really important. And we're really fortunate here in Johnson County that we have a type of criminal justice database that would allow us to just automatically flag these individuals that they are within the age range to be assessed for this Medicaid eligibility. Then we have a system that integrates our various data systems, which would then allow us to be able to inform the proper agency that this person was in our jail or ready to be released. If you don't have that, I think having reentry services embedded in your jail is such an important component to be able to do this well. And then the next piece, I think, is the ability can we start this before someone gets out? And if we can't, as I've talked about here repeatedly already this afternoon, but if we can't do that, is it possible that when that person's released, that we're able to take them to make that connection, to make that warm handoff to the agency? That would require some pre-planning where we're informing that agency that, hey, Mike is getting released on Friday at 2 o'clock. Can I bring him to come see you at 2:30? It's such a, you know, I've always encouraged my reentry case managers within 24 hours, even if it's at a coffee shop or McDonald's, make sure you sit down with that person in the community. So I think, and connecting these individuals is really important. So those would be kind of the areas I would emphasize. But I would also want a specific plan that we have created for our community that I can share with those other resource providers, so that we all know what the roadmap is. And I know what my role is in working with reentry. You might know what your role is in working at the mental health center or the housing provider. We know each other's limitations. And that way it just makes for a smoother experience when we all try to work together to serve one individual.
Yeah, absolutely. I think that shared case management, and ideally before someone's reenters, getting any providers to the table to really discuss that transition in the correctional facility is really important. We did get a follow-up question, Mike. I think this is a popular one, is how can you identify the people who have aged out of the foster care population? How would you be able to do that in Johnson County?
So here in Johnson County, we have an automated system that would allow us to see that. How can I explain this? We have a case management matching system. So if someone gets booked into jail, that case manager is going to be notified. So that individual in foster care, the service provider will get notified that someone's become incarcerated. Then, you know, we have then educated all of these agencies so that they know who they can contact at the jail to make sure that happens. The previous county in Douglas where I worked, the local Division of Children and Family Services agency had a jail liaison assigned to the jail. And she would then be that point of contact to say, hey, you've got one of ours. And then the reentry team would work with them from there. We always loved it when we got those cases because we knew that these services were already lined up and available to them. So that was great. And can you imagine a vision where we had that for everyone who was released from a prison or a jail? I think one of my peers here made a comment earlier about starting with this subpopulation gives us an opportunity to learn things and build connections, which then can expand to work with all of our populations.
Yeah, absolutely. And if you're a jurisdiction that doesn't have as sophisticated as a partnership with foster care system yet, try to reach out to state and local leaders and build that. You know, a lot of this just is reaching out and trying to start the dialogue if that's something that you haven't had the opportunity to do yet. And thinking about who the leader, whether it's the sheriff, the head of the Department of Corrections, a judge, prosecutor, other local leaders who might be able to help with that outreach. So Maddie, I'm going to ask you from a strategic planning perspective, what steps should be taken to ensure successful integration of Medicaid service for young adults during reentry?
Yeah, I think in addition to building the partnership with our partners in DYS and correctional facilities, one thing that we really want to emphasize a critical step is to better understand and improve how data sharing works between justice partners and Medicaid. That's like the essence, it seems, and it's a beast to untangle. So data sharing between correctional agencies and Medicaid, it's just so crucial to ensuring that youth and anyone are getting the best coverage possible for their needs and are taking advantage of all the resources upon release. So one example, just to make it concrete, is in Mass Health, we have a whole host of care coordination programs to support members navigating their healthcare and identify supports, whether that be connecting with a behavioral health therapist or support around housing and other social needs. But ensuring that youth are connected to these programs post-release is crucial and depends on the ability for us to identify when a youth is entering the community. And so we know that is complicated to time release, but If you can get started in that as soon as possible, I think that would be super helpful to the policy work.
Thanks so much. And Sheriff, what are your thoughts on what steps people can take immediately to try to ensure a successful integration of Medicaid services for young adults during reentry?
Well, one thing that lesson I think applies for both the 18 to 12-year-old implementation and the MIEP waivers is really something that we struggle with across all systems, is the siloing of what we've got going on, and building that cross-system collaboration is crucially important now more than ever, of course, but it's been important for a long time. And unfortunately, we're missing too many people that are cycling through each of our silos and not being picked up by the overall system, so to speak, right? So I think that bringing corrections to the table early has been really helpful, because we can help execute the policy that state health policymakers develop in a meaningful way that'll bring the most benefit. So bring, sheriffs and their subject matter experts. Sometimes it's more the subject matter experts than just the sheriffs themselves anyway. And the people with lived experience. This is one thing, the people with lived experience, bring them to the table. Again, this is a voice that we often forget, because we think we know what's best for them, but we never actually ask them. And their input is really important, because as I said, they'll come up with, or I said before the call, they'll come up with stuff. People come up with stuff that you didn't think about. So you have to get them in. So I think that's why, last year we got a coalition of law enforcement associations, Major County Sheriffs of America, National Sheriff's Association, Major City Chiefs of America, and NACO, to endorse the Support Act and to push for the ending of MIEP. Hell, I was there with basically Ed Markey and Al Franken 12 years ago doing this in Capitol Hill a long time ago. And it's nice to see it coming about. So I believe the voice of law enforcement will really help to add to what the public health community knows is also true, because you just need a little bit of that on the other side of things. I always say that my work sits at the intersection of public health and public safety, and seeing it through my lens of a public health sort of person, it informs me and helps me do a lot of things really that help my population a lot. I deal with the same issues in population as sheriff that I did on the committee with healthcare, and that Maddie faces as well. So I just said, as I said before, we have a generational opportunity to deal with the same issues in population at the intersection, to break down those silos, to build a properly integrated model. And again, as I said before, shame on us if we don't waste that chance. And Mike said something really important. Our planning for reentry starts on day one of their carceral stay, right? People think, oh, you start planning a month out, 6 months out, whatever. It's on day one. The whole plan inside is to be preparing them for their outside. On day one, good corrections. Mike said it really well. So it's that continuity of care from the outside to the inside, back to the outside, that will be really important. That'll bring the greatest benefit out of this. I mean, you can save monies here and there, but the fact is, it's that continuity of care that will have the greatest benefit. And it's really important for people to really remember that in-reach and outreach, at a time when they were alone in their facility, carceral facility, and no one cared about them, and the only people that would visit them or call them were their moms, their grandmothers, their wives or girlfriends, or their spouses, or whomever it is, for the men anyway. And their friends never called them, their friends never visited, and who are they going to go out to? It's so important to have that trusting relationship built with the providers that they're going to go out to when they get back out there, so that it turns a social network, which is the reason for so much recidivism, they're hanging around with the wrong crowd. It turns it on its head and keeps them out of jail and keeps them healthy. I think that we don't value the issue of social network enough, and I think this can be providing something great. Like Mike and Maddie are just right on this, and the CSG Justice Center, thank you so much for this work. Crucially important, and I applaud you for stepping up at this time.
Thanks so much. So we have a couple questions from the chat. So Jennifer is asking, has anyone in the panel ever run into resistance in implementing services for the young adult population? I'm seeing, Mike, you're nodding your head. Do you want to take first crack at that?
No, absolutely. Thanks, Sarah. I mean, we only have 8 minutes left here. I could go on and about these, but So housing is really a barrier, and often would see landlords who might rent to an older individual who would not be willing to rent to a younger individual. And then I think oftentimes the interesting family dynamics can be a real barrier in working with these individuals. Some family maybe wants to have written someone off or is trying to set boundaries, but yet they want to have influence on the decision that the individual is making. So that can be a significant barrier. And then oftentimes too, in dealing with young adults, and this is unique to those being released from incarceration, but it is the fact that they're still at a point in their life where they have hopes and dreams, and to understand that I might have to deal with addiction for the rest of my life, or I might have to deal with mental health issues and take medications, or that somehow I'm not a normal young adult, is a really difficult thing to deal with emotionally at that point in someone's life. So those are a few of the pieces, and oftentimes then too, I think a lot of times the behaviors that they struggle with in the community get written off as behaviors, not necessarily symptoms of an illness or an addiction.
Yeah, if I can just add to that a bit, Sarah, I mean, Mike's absolutely correct. There's resistance all around. Anytime you try something new, there's resistance, right? You need to educate people. And I think if you have the trust of a community, you can actually get them to at least give you a shot at it, right? So when we started our very first young adult offender, again, it was the first of its kind in a jail in the nation. By the way, more important to put them in jails than prisons, because you got 10 to 12 million people cycling out of jails into communities, and only 500,000 or 600,000 people from prisons cycling into communities. So you can actually do more good in the jails. But I was met with inside resistance. The young people inside a carceral facility are the worst, right? They're in the most fights, they're most maladaptive and sociopathic behaviors and stuff like that. Well, it's no wonder, because one, they usually had trauma. We're about to start an ACE inquiry in our facility, but guarantee you that like every one of them had trauma, like every single one of them had trauma. And when we started the unit, we had to suddenly make adjustments because we didn't appreciate the level of trauma they faced. So it was something interesting. But what we found was that after the training actually made the lives of the officers better back at home, because they know how to deal with their own relationships at home. Cognitive behavioral therapy here helped them with this, and their own children. And even some of my own leadership that's gone through the training. By the way, this training we now offer to every single member of the Middlesex Sheriff's Office, not just the sworn members that work in that unit, but every civilian, because we know the benefit it brings. When you're dealing with your child and you're going bottom brain, and then you kind of go back to the CBT training and you kind of go top brain and you handle it better. So what we found is also inside, it went from this age group being the worst offenders to this age group in this unit being the least of the offenders, compared to even their age group and the rest of the facility. So a significant difference. Now, it's more intellectual work, a little bit more emotional work, but there's also more valuable and rewarding work inside as well. But then you go to the outside that people just don't understand these people. But if you have partners, and Mike, you might have this there, and Maddie would know these, UTEC and ROCA, which are gang engagements or youth engagement, troubled youth engagement organizations, that can then be that party that can kind of bring them inside, do some of your training, and then support them on the way out. They have the buy-in of communities as well. They can make it an easier acceptance for people to understand what you're trying to do and to give you that trust that we really need to make this work.
Yeah, absolutely. And I think it's really an important point, because when you're focusing on this population, you can see real gains, and you always hear people can potentially age out of crime because risk factors for young people are greater. They are at higher likelihood to re-enter the criminal justice system. So really focusing on this population makes a lot of sense from a cost, a public safety, and a health perspective, which is part of the reason why this opportunity to use Medicaid funding and leverage that opportunity is so exciting. So one of the questions in the chat, and we have a couple that we hope to get to. One of them is actually about collaborating with community health centers. And Maddie, I know in Medicaid, that is a big focus of your work. Can you talk a little bit about suggestions on how people can connect with community health centers if they're not already? I think it's more common with correctional agencies to be connected with behavioral health providers than with community health centers or federally qualified health centers.
Yeah, so we have a long-standing relationship with the Massachusetts League of Community Health Centers. So I would look into an equivalent in other states at an entity that kind of represents all of the community health centers as a starting point, because they offer a great connection to the whole menu of community health centers, and then also as needed to have individual conversations with CHCs. But they're been a critical partner in our work here.
And I'd be remiss if we didn't mention that HRSA, the Health Resources Service Administration, just wrote some guidance to promote community health centers supporting reentry processes and connecting with local correctional facilities. So I think there's a real opportunity there, in addition to really think about and try to get some new partners if you haven't been working with community health centers as well. So the last question we are going to field before we close out is, how do you currently connect young adults with therapists? And Sheriff, I'm going to start with you, since I think that may be a part of your program.
Yeah, we do establish those relations. I mean, listen, that it's hard enough to find a therapist for anyone, but it's especially hard for young adults, right? And so this is at a premium right now. But we've been working with the Behavioral Health Justice Initiative, which provides supports and navigators for those that struggle with mental health. So that's just a little bridge that we can provide, but it's really creating those connections on the outside that are the most important thing. I mean, listen, I always say when people leave our facility, they go from a couple of months out from being excited to a few weeks out of being really nervous. Right. And they get this look on their face. It's a very different look than they had just a month or two earlier, where they're scared as all hell because they're like, how am I going to make it work? I haven't been able to make it work sometimes in my life before. So creating those connections with the community health centers. And by the way, Maddie, I'm going to be speaking at the annual luncheon of the community health centers. And, I think it's kind of cool that we're having a sheriff come in and speak with community health centers about this. That's the relationship that we have, thanks to people like you, Maddie. But creating those connections, and it's hard because when we started our first medication assisted treatment program, I had to go out and I had to hit every darn community health center, every darn provider, every hospital I could to get them to jump on board. So a lot of this is going to have the work that we do in building those relationships with the community members, so we have that automatic transfer of caseload directly out there. And the BHJI helps us do that a lot with the navigators that could support these individuals as they're leaving.
Thank you so much. And I want to take this time to thank the panel and thank you for the discussion in the chat. We had great examples called out from California, Wisconsin, and other places within this. So lots of people are super excited about this opportunity. We really want to make sure that corrections leaders are aware of these new opportunities to support young adult through leveraging Medicaid funding. Starting January 1st, 2025, we look forward to the Center for Medicaid and Medicare Services guidance on how to better support this. You can reach out to myself or my colleague, Bridget. Big shout out to Bridget, who helped organize all of this. She is the person behind the screen here who did all of this work to support this panel. And through the Second Chance Act, training and technical assistance, we're able to answer questions related to Medicaid and corrections. Our focus is really making sure justice leaders understand the opportunity and corrections leaders more specifically. So feel free to reach out if you have any questions. And we look forward to hearing from you. Thank you so much, Maddie, Mike, Sheriff. We appreciate your time, and have a great afternoon.
Thank you so much. Bye-bye.
Bye.